I'm delighted to be able to be with you today at the GenTAC Aortic Summit organized by the Marfan Foundation to discuss the topic of medical management of bicuspid aortic valve disease, focusing where possible on evidence-based practice. I see bicuspid valve disease as really a complex that includes the bicuspid valves, of course, that occur in 0.5 to 1.5% of the population, approaching the population prevalence of mitral valve prolapse. Half or more of patients with bicuspid aortic valves have at least slight enlargement of a portion of the aorta, most commonly the ascending aorta, more commonly than the root or the arch, with little or no involvement of the distal aorta. Coarctation of the aorta is associated with bicuspid valves, and these may occur in varying combinations. Interestingly, when we look in families, relatives of patients with bicuspid aortic valves may have aortic dilatation or coarctation with trileaflet aortic valves. Major complications of bicuspid valves are aortic stenosis or regurgitation requiring surgery or transcatheter aortic valve replacement or aortic dissection. The recognition of aortic enlargement by echocardiogram was really pioneered systematically by my colleague, Dr. Mary Roman, who recognized that both age and body size influenced the normal range of aortic sizes and published these nomograms at different ages that have been widely employed to detect enlargement of the aortic root. We used Mary's work in a study that she supervised that was led by Becky Hahn, who's now at Columbia, looking at patients with bicuspid valves who had functionally normal valves, mild or severe aortic regurgitation or aortic stenosis, and demonstrated that all groups had frequent aortic enlargement at all levels, most commonly with severe aortic regurgitation, and more commonly at the sinotubular junction, which is the beginning of the ascending aorta. A more recent study limited to patients needing aortic graft surgery, so none had normal aortas from Yale, showed a predominance of patients with predominantly ascending aortic dilatation, over 60%, or a combination of aortic root and ascending aortic dilatation, 25%, with a smaller proportion having dilatation limited to the aortic root. A subsequent study from Julie de Bakker's group in Ghent, Belgium, in which Mary and I were privileged to participate, developed user-friendly nomograms for the upper limits of normal, for the aortic root at sinus of Valsalva in the upper panels, and the ascending aorta in the lower panels, separately by gender, that can be used to identify aortic dilatation efficiently. This slide shows unfortunate consequences that occur if one focuses on the aortic root alone. This young man with a bicuspid aortic valve where was interpreted as being about 5 centimeters from the root, but the ascending aorta was 7 centimeters, and the patient, a few days after the echocardiogram, suffered a fatal aortic dissection. On the topic of aortic dissection, this is an important study that I believe has already been mentioned by my colleague, Dr. Jonathan Weinsaft, in which the rate of incident aortic dissection in the GenTAC population was compared between patients with Marfan syndrome or with non-syndromic aortic thoracic aortic aneurysms, about half of whom had bicuspid aortic valves. And the rate in the bicuspid valve or trileaflet non-syndromic aortic aneurysm patients was about 1/6 that of Marfan patients, which is consistent with the increasing recommendation to recommend preventative surgery at somewhat higher aortic diameters than in Marfan syndrome. Here we go. Now, there's, as of 2 years ago, one published comprehensive guideline on many aspects of bicuspid aortic valve-related aortopathy from the American Association of Thoracic Surgery. This discusses imaging, among other things. Echocardiography is the workhorse of imaging, widely available, can image the aortic root, ascending aorta, and arch in most patients with use of views that may not be used in every laboratory. CT angiography is widely available for 3D visualization, entails radiation and use of X-ray dye. MR angiography is less available for 3D visualization, has low risk of contrast problems, but common claustrophobia. And imaging is needed initially and intervals depending on aortic and valve findings from 6 months to 5 years. One important question is the degree of familiarity of bicuspid aortic valve. Here are 3 studies looking at the proportion of first-degree relatives, parents, siblings, or children of index cases with bicuspid aortic valves, finding that from 9 to 24% had one or more relative with either a bicuspid valve or dilated thoracic aorta or both. Now turning to bicuspid aortic valve medical management, this shows the literature for randomized treatment trials. So the question, is it too early for a randomized trial, since there have been none to date? In the absence of treatment trials of preventative medication or exercise limitation, other than studies that turned out negative to prevent aortic stenosis progression, many of which excluded bicuspid valve patients, and those trials were negative. The standard practice is to control hypertension to normal blood pressure, and many cardiologists reason by analogy and treat bicuspid valve aortopathy similar to Marfan syndrome with use of beta blockers and/or angiotensin receptor antagonists. My personal practice is to use these agents to keep blood pressure in the low normal range. Many of my patients sometimes come in with systolic pressures at 100 or below, adding salt to diet if needed to prevent orthostatic symptoms. And according to the 2007 American Heart Association guidelines, infective endocarditis prophylaxis for dental procedures is reasonable only for patients with underlying cardiac conditions associated with the highest risk of adverse outcome from infective endocarditis, which did not include bicuspid aortic valves. The 2008 UK NICE guidelines went further and suggested total abandonment of endocarditis prophylaxis. However, 2 recent studies indicate 17 to 23-fold higher risk of infective endocarditis is associated with bicuspid aortic valves. Turning to population-based data from the UK, a paper published a few years ago in The Lancet shows on the left-hand side the dramatic drop in prescription of antibiotics for endocarditis prophylaxis. And on the right-hand side shows a shift to a higher plateau in the incidence of endocarditis in the United Kingdom. A subsequent study by the same group using Canadian data showed that the increase occurred in patients at high risk for endocarditis, not those with valvular conditions at low risk for endocarditis. Turning to pregnancy in women with bicuspid aortic valve aortopathy in 2010, the AHA aortic guidelines did not mention anything specifically about bicuspid valve associated aortic disease, did list a number of recommendations with low-level evidence. The more recent European Heart Association guidelines on pregnancy in women with cardiovascular diseases focus more specifically on bicuspid aortopathy. They recommended that pregnancy should be avoided when the aortic diameter is more than 50 millimeters, that patients with aortic pathology should be followed by echocardiography during pregnancy and the 6 months postpartum, which may be the highest period for dissection risk. The frequency suggested ranged from every month to perhaps once each trimester. Cardiac MRI without contrast can also be used, particularly if echo imaging is suboptimal. They recommend pregnancy being managed with an obstetrician and cardiologist who understand aortopathy and advise strict blood pressure control with medications deemed safe for the fetus. In women with heritable thoracic aortic disease, beta blocker therapy throughout pregnancy should be considered, as is commonly used in Marfan patients. This shows a relatively large number of recommendations with still obviously no trial-based data, but quite a few class 1 or class 2A recommendations. So to summarize, patients with known bicuspid aortic valve or a positive family history of either bicuspid aortic valve or a coarctation of the aorta should have imaging of the aortic root through the aortic arch at baseline and at intervals thereafter, depending on findings on the degree of enlargement of the aorta and or the degree of aortic valve stenosis or insufficiency. Echocardiography is most widely used, but needs to be used with considerable care. Echocardiograms done in hospitals with active heart surgery programs tend to get good to outstanding quality imaging of the proximal aorta. MR angiography or CT angiography can be used for 3D imaging and have advantages under some circumstances. Blood pressure control to normal levels is clearly indicated. Many, including this speaker, treat to lower targets with beta blockers or ARBs. Pregnancy considerations are similar to those with other non-syndromic aortopathies. Emerging evidence that bicuspid aortic valve is at high risk for endocarditis, especially with significant aortic stenosis or aortic regurgitation, suggests that effective endocarditis prophylaxis is indicated, though we have to wait for the next round of US and UK guidelines to have that officially sanctioned. And the occurrence of affected relatives with bicuspid valve or proximal aortic disease or coarctation of the aorta in from 8 to 20% or so of families suggests that family screening is valuable to identify cases of patients who may benefit from further surveillance and management as we have discussed. And in summary, I'm pleased again to thank the organizers of the GenTAC Aortic Summit and the Marfan Foundation for the opportunity to speak with you today.